Hello, everybody. I am Alexa Tinsley. I am the Director of Programs for Jett Foundation. Thank you all for joining us today. We're going to go ahead and give another minute for everybody to hop on. But while we're waiting, if you could please put your name, location, and either you or your child's age in the chat, that would be wonderful. And we will be back in just a moment. All right. Thank you guys for hopping on. Again, my name is Alexa Tinsley. I am the Director of Programs for Jett Foundation. Thank you all for joining us today on our for our community webinar series. Our topic today is palliative care. I want to thank Dr. Ashley Nichols from Children's of Alabama for helping us make this webinar possible and for sharing her knowledge and expertise with us. I know I've heard in several cases that this is knowledge that's really needed in the community and not always well understood. So I really appreciate her coming on and helping us educate our community on this topic. So Dr. Nichols works clinically both inpatient and in the clinic at Children's of Alabama and UAB. In her time at Children's, she sees patients at the Adolescent Young Adult MDA clinic as an embedded palliative physician. And I also learned that she used to be an MDA summer camp physician, which is always near and dear to many. Before we get started, I do just want to mention a few things. If this is your first webinar series, we do offer these throughout the years on various topics. This is also being recorded, so if you aren't able to stay on the whole time, if you lose connection, or if you know anybody that wanted to be a part of this webinar and was not able to for some reason, it will be recorded and listed as a resource on our website and will be on our YouTube to watch later. It is also being streamed to Facebook Live, which it'll be on Facebook indefinitely for you guys to watch as well. After the presentation, we will be answering questions. There is a Q&A box. It's a panel. It has like two little message boxes. For me, it's at the bottom right-hand corner of my screen. We do primarily use that to answer any questions, but we will try to monitor the chat. We also do look at Facebook and try to monitor those questions as well. So if you do have any questions, please put them in the Q&A boxes. That's what we primarily go through. And with that, I'm going to go off screen and I'm going to hand it off to Dr. Nichols. So thank you again.
Thank you, Alexa. I am so excited to be here today, so honored to be asked to present, and just really enthusiastic about the desire to learn more about palliative care and what I do, what my colleagues do, and how we can hopefully help partner with your MDA team teams throughout the country. I know that looks different depending on where you're from, but I'm really excited to kind of share my perspective and kind of my role over the last 15 years or so that I've been working with muscular dystrophy. So to get us started, I think first and foremost, wanting to make sure we're all on the same page with what is palliative care. This can be a very confusing, a very controversial topic sometimes. I put this cartoon in because it's just a great reminder for me, especially as a medical provider, that we often tailor our medical care around just kind of medicine. As physicians, especially, we can get so sidetracked by the ailments that we see in front of us, by the medications, by the procedures that we need to do, that sometimes we forget about the human in the bed, about the child in clinic, about the family in the community, and what we're doing kind of can add to the burden. And so as a palliative care doctor, I work really hard to kind of step back and kind of see my patients more as a whole person, and how they experience kind of illness and kind of their disease, and how we can better take care of them and their family and their community. So to start us off, very nerdy, and I promise I won't use any more Latin root words, but just to get to the crux of why we're called palliative care, this actually stemmed from the Latin root pallium, which was really just an outer garment or cloak. So, you know, idea of like a raincoat kind of cloaking a person from the inclement weather, right? And so we really used this, kind of took that meaning and kind of, you know, twisted it a little bit and said, how can we cloak our patients and our families from the symptoms and suffering of serious illness? And thus the field of palliative care was created. There's a lot more to that, of course, but I think one of my favorite definitions comes from the Center to Advance Palliative Care. And what I love about the Center to Advance Palliative Care is they really have a lot of community engagement, really looking at how did palliative care start? What were perceptions of patients and families of palliative care, and how can we partner with them as we grow our field and kind of change our field to better meet the needs of our patients and families? And so they actually partnered with patients and families to create this definition. And what we have here, palliative care, specialized medical care. So just highlighting that most palliative care providers have an extra layer of certification, fellowship, whether they're a social worker, a nurse, a physician, a chaplain, you name it, kind of really seek some added specialized knowledge in how to take care of patients with serious illness. And serious illness is broad intentionally, that it's not end of life illness, it's not cancer related illnesses. It really is any illness that seriously affects how a patient lives life. And so our focus is on providing patients with relief of symptoms, pain, stress from their serious illness, regardless of the diagnosis, with the goal to really improve quality for both the patient and the family. So we can only do this by providing palliative care within a team. And so often a palliative care team may have physicians or nurse practitioners, but often partner with nurses, social workers, even chaplains sometime as part of a kind of unique palliative care team. Whether or not we have other members on our team, you'll see I partner more with my MDA partners and specialists. So we're partnering with whatever specialist you or your loved one has to really add an extra layer of support. So it's not meant to take anything away or be exclusive of the type of care that you're already getting. It's really an add-on to kind of figure out what else can we do to kind of put these pieces together and better support this patient and family. It's appropriate at any age, any stage. Some people will be surprised that we see pediatric patients as well as adult patients. But I think all of us are aware that it doesn't matter how old you are. If you have an illness that's affecting how you live life, it's really important that we think about this more broadly. And then, of course, as I mentioned earlier, it's not exclusive. It can be provided together alongside kind of curative treatment. So I love this definition. I think it's a good broad definition that kind of highlights some of the things that we focus on. When we think about pediatrics, because I think we probably have a lot of parents here today, I think the American Academy of Pediatrics has been very supportive of as we've grown our field within pediatrics and kind of really supporting an integrated model. So kind of partnering with those specialists again, where we're offering components of our care anytime along the stage, so at diagnosis and continued throughout the course of illness, whether or not that illness ends up being cured and is no longer an issue, or it progresses and may even end up in death, kind of knowing we can be helpful in different increments and using different services depending on what stage we're in and what we're dealing with for our patients. And so this is a play on words a little bit that I really appreciated. One of our palliative care teams up in Akron used to use, but they called their team a palette of care. And this really, this analogy just rung true to me because I think of all the different kind of pieces of art, all the different ways that art can look depending on what services you're using, what colors you're using. So we're partnering with kind of the teams that you have to treat more complex symptoms as we really work to relieve physical and emotional suffering. I think most of our providers, if you're in an MDA clinic, we have lots of great providers who are experts in their field, who really know how to treat kind of our common symptoms that we see. But when those symptoms get more complex, as they start to kind of meld together, kind of one affects another, sometimes having an expert that can weigh in and kind of partner with your rehab doc, your neurologist, to really think outside the box and figure out how can we better tackle this symptom can be really helpful. And then the piece that I think I enjoy the most is really just being able to partner with patients and their families and their clinicians, kind of that MDA team, to really strengthen how we communicate with each other and make decisions. Not, it's broken, this is how the doctors want to treat it, but more, hey, this is what's going on. What's most important to this patient, this family, and what makes sense in that context? How do we engage patients and families to be an integral part of that decision making? And that's the piece that I enjoy so much, especially as I get to watch my patients kind of grow and develop and change over years in clinic. So in order to do this, most of us in palliative care would describe us approaching medicine from a slightly more holistic approach than might be traditional. I think certainly in medical school, I can speak specifically to that. When we learned about suffering and treating suffering, it's very easy to get swept up in physical suffering. So thinking of pain, nausea, trouble sleeping, whatever might be going on, constipation, to name some common things, and to figure out, spasticity, limited mobility, whatever is going on. And we have some great opportunities to treat that and to kind of focus there. But I think what I try to do is really step back and recognize that patients with muscular dystrophy, or a lot of our diagnoses, their physical ailments, kind of how that affects them physically, is a huge component of their suffering and kind of what they're dealing with day to day, how this affects how they live life. But with that comes an emotional toll, how they're processing, how their body's changing, how they're coping and adapting. Some of those natural processes, and then some of those more pathologic as they get more engrossed and might have more depression or anxiety associated with their diagnosis. Certainly, I think all of you are very aware that this doesn't just affect a patient, it affects a community. It affects the social environment that this patient is in, so that the family, the caregivers and caretakers, the people they go to school with, go to church with, do things in the community with, kind of how all that interplays, how they're able to exist in their community and how that affects their experience of illness. And then last but not least, certainly acknowledging, especially as patients grow and develop, they may have a faith or religion that kind of helps them make sense of a diagnosis or find meaning. But I think more globally, just as people develop and grow, trying to make sense of illness and kind of, what does this mean for me? How do I make meaning kind of in the time that I'm here? And how do I make sense of the things that are happening to me? And so recognizing that being able to really step back and look at all four of these components helps us treat our patients and families more as a whole. And sometimes that's how being able to step back and not be as laser focused on a certain specialty or diagnosis can really kind of help me kind of see a little bit more big picture and help guide patients and families. All that said, that's a lot, right? Any one of those things can be a big deal. And so the only way this can be done is really from an interdisciplinary approach. And so this is my second palette of care. Not any one provider can do this, certainly not well, right? And so I'm coming at it from the physician perspective, but I can tell you I couldn't do this well without partnering with my other physician specialists. So we are blessed in our MDA clinic to have a rehab physician, a neurologist, a pulmonary and sleep doc, a cardiologist, genetics and genetic counselors, and even psychiatry psychologists. And so partnering with all these specialties, recognizing each of them has their area of expertise, and we may just need help to link what we're doing together and making sure we're not working in silos, but each piece of the pie kind of makes sense as a whole. Similarly, our therapist bubble is huge, right? Y'all are all familiar with so many of our therapists, but recognizing there's a lot that our PT, OT, speech therapists kind of bring to the table as we're taking care of our patients and loved ones. Additionally, we have respiratory therapy in clinic, and we partner with CRS, Children's Rehab Services, to provide vocational rehab, especially if that's important for a child that's transitioning kind of out of school into a next phase of life. Certainly, of course, our child life therapist helping as our kids are developing and kind of understanding illness in the context of their appropriate age appropriate development, helping with siblings, things like that. Respiratory therapists, music and art therapists. I am probably leaving people off, I'm sure, but just seeing how broad the team is. And then, of course, you can see our nurses, social work and case management colleagues, spiritual health chaplains, community leaders, and then kind of counseling as well. And so this really thinking about the 4 domains of suffering, how they affect a patient, how they affect a family, a community, really requires us to engage as a team and not only work well in our area of expertise, but to partner together to make sure we're not leaving any gaps. So why me? How did I end up in a muscular dystrophy clinic of all things? I think just a little bit more about me. I was trained in med peds, so a combination of internal medicine and pediatrics. And here in Birmingham at the time, we had a pretty robust palliative care service at our adult hospital, but not at our pediatric hospital. And so I could see patients living with chronic illness, even see some some ALS, some muscular dystrophy patients that had transitioned into the adult world, the services that they were getting, and kind of what wasn't there for them in pediatrics. And so that was an inspiration to me after residency to do a combined training, to be able to walk that bridge over and make sure our pediatric patients were getting the same level of care and even a tailored level of care specifically for pediatrics. And so as a fellow, we're required to have clinics and really see more longitudinal care across the year. And so I was blessed to be assigned to Muscular Dystrophy Clinic as one of my 2 clinics. And so really fell in love with this patient population. And so my clinic, we have, I think, 5 half days of MDA clinic a month, one of which is really targeted at adolescents and young adults. And so it's predominantly Duchenne muscular dystrophy, but certainly has some others that are pulled in, but in an older age group, usually 14. It was up to 35, but we've started transitioning patients over to UAB and into our adult hospital setting. So I don't get quite as old anymore in this clinic. But in that, as Alexa mentioned, I had the privilege of getting to work as the muscular dystrophy camp doc for 6 or 7 summers in a row. And that was just spoke volumes to me. It's one thing as a provider, we see patients when they're at their worst, right? When they're sick in the hospital is about the lousiest time to meet a patient and a family. Even in clinic, what adolescent male is super excited about being in clinic for 3 hours? I'm not seeing them on their best day, right? And so it was meeting kids like Matthew and seeing them karaoke at summer camp or tell jokes at the talent show or whatever was going on that really let me in on seeing kind of life with muscular dystrophy. So here's Matthew again, zip lining. He, of course, gave me permission to show these pictures, or his family did. Just seeing the joy that these kids could have, the life that they were living, even with their muscular dystrophy diagnosis, and how we were really trying to empower them to live their best lives. Here's me with one of our home vent patients at home vent clinic or camp, and my friend Logan, kind of swimming it up, living life at muscular dystrophy camp in the pool. And so this has been my inspiration, and really getting to know these kids early on and over time, and getting to see them kind of live life and celebrate moments with them has been a great inspiration to continue on in this clinic and with this patient population. So I talked about one of the things we do is, of course, more complex symptoms. So really kind of thinking about mainly that physical bucket of suffering, but sometimes that emotional bucket as well. There are lots of symptoms that you're probably very familiar with. Some of you may not have had to deal with many of these. Thankfully, some of you may be in the midst of many of them, but certainly partnering to treat different pain syndromes. I do a lot of partnership with rehab and neuro, especially for different types of pain, depending on what we're dealing with, whether that's related to spasticity or contractures or scoliosis, or even kind of more complex neuropathies and kind of central or nervous system related pain syndromes. Sometimes nausea, especially as maybe a feeding intolerance progresses. Constipation, very, very common. Of course, you can imagine the most exciting things my teenage boys want to talk to me about. Difficulty swallowing, maybe a lower appetite with weight loss, sleeping difficulties being very common. And then certainly a mixture, and this kind of dips into that emotional bucket, but how their processing changes in their trajectory and kind of how they're coping with those changes and maybe dealing with sadness or loss or worry or just frustration as their body changes and their abilities change. And making sure we're opening up the floor to explore these symptoms, giving them permission to talk about them and plugging them in with resources and plans when they are experiencing these symptoms. I think a great way to kind of tell more about what we do is from learning from a story. And so I want to tell you about my friend John. I think you'll see a good number of symptoms that we treated with John over the years, but I think really that second piece that can be more vague, that kind of helping with decision making, can really change over time. It's not black and white. I think y'all are probably more familiar with this with anyone else, but we make decisions based on what's going on right now. And we all have permission to change our minds, to learn and to kind of change how we feel about things, how we think about things over time. And so navigating that, how dynamic decision making can be based on what we're learning from our kids and with our kids and what they're experiencing as they grow with their muscular dystrophy. So John is a 20-year-old. He has Duchenne muscular dystrophy. I have known him very well. I met him first at camp when he was young and then kind of got to follow him in clinic over about 8 years. So he's usually in clinic with his mom, sometimes with his dad as well. And in clinic on this day, he's really complaining of worsening kind of muscle aches, but particularly some low back pain and difficulty sleeping that have been bothering him in the 6 months since our last visit. So as we think about our review of systems, as we just kind of go down, we have different specialists that are kind of knocking out different pieces of this. You can see highlighted in blue that he has lots of symptoms that come and go kind of throughout the days and weeks. Some fatigue, I think the most troublesome, as he had been mentioning, just restless sleeping, a little bit more progressive difficulty swallowing, and we'll talk more about that. Constipation. He feels like he's having to go to the bathroom more frequently, and that's really bothersome to him. So that kind of came up as we explored and kind of prodded a little bit more. Most adolescent males are not just jumping at the chance to tell me about their stool and urination habits, but certainly with some rapport and some questions, they'll open up more. He was very quick to tell me about kind of cramping and that low back pain. And then we noticed he did have some thinness and redness over his sacrum as he was getting a little bit skinnier from his difficulty swallowing. So lots of things to kind of be thinking through in our clinic visits over time. This is a story you may be familiar to many of you. John was diagnosed at age 4 after some falling and difficulty running, keeping up with his peers. He lost independent ambulation at age 13, has required some assistance with mobility since then. Had spinal fusion for scoliosis at 15. Has severe restrictive lung disease now. He's only been on the breathing machine once, and that was for his spinal surgery, but he does use BiPAP at night for his lung disease and his sleep apnea. And then has had some more progressive difficulty swallowing, had some weight loss, and so got a feeding tube the year prior. When we take a step back and think more about John socially and in his community, he lives with his parents. He has a younger brother who also has Duchenne muscular dystrophy. His father works outside the home, mother works just as hard, if not harder, inside the home, caring for both boys. His younger brother's still in school, but he has graduated and is interested in pursuing vocational rehab, really trying to find purpose in these post-school year days. Similar to many, John is on YouTube, but most of the time he's on his computer. He enjoys some graphic design and has thought about some classes to explore that a little bit more. And then interestingly, as I've known John over the years, one of his good friends from muscular dystrophy camp passed away the year prior. And so that's something he's been processing and kind of really affecting how he's experiencing his illness moving forward and kind of some of the decisions that he's making. So when we think about physical symptoms for John, we mentioned generalized pain. He certainly has some muscle contractures. He has intermittent spasms. Remember, we noted some skin breakdown from his weight loss. And then certainly we've had to really think about how we give him medications now that he has a feeding tube and isn't able to swallow pills as effectively anymore. When we explore a little bit more about his restless sleeping and difficulty getting to sleep, it's been helped some by his BiPAP, but as you explore it more, it's really more related to anxiety. So we're going to dig into that a little bit more as we think about kind of emotional suffering and kind of some of the common things that we see with some of our patients with muscular dystrophy. So this grieving the loss of just autonomy, this natural process of losing some physical abilities often can change how it affects them emotionally. Wanting to be able to like get a job like all their other friends that have graduated from high school and make money and contribute to the family or do something that has purpose, that they see kind of purpose in. Sometimes difficulty having self-confidence, being an individual because they're so linked to the people that are providing their care. And for some, even sexual identity questions and how do we have relationships when we're so dependent on others for our physical needs. So a quote that I saw once that just kind of stuck out to me is that for patients with chronic disease, adolescence can often be a paradox of these emerging capabilities as they mentally have so much more capacity and so much more curiosity, but diminishing possibilities as their bodies are not cooperating with them as well, as they're not able to do as much with their mobility. So when you dig in for John, as I mentioned earlier, his insomnia was really related to anxiety. He had this fear, especially since his best friend passed, of just not waking up and how that would affect his family. But I think more immediately, just making sure, is someone gonna, if I wake up and need help, how are they gonna be able to hear me? Are they gonna be able to get to me fast enough? So some of the logistical pieces that we navigate with our patients. When we think about, he described sadness, worry, but it was almost always related to others and not actually for himself. Certainly I mentioned experiencing the loss of his friend. He worried about his younger brother, who he's seeing kind of having a mirrored trajectory to him. And then just feeling kind of the weight of care of he and his brother over for his parents. And so really kind of navigating those as he's just coping with kind of changing illness. What about that social bucket, that psychosocial suffering? And so kind of knowing kind of in that our kids often have an increased risk of normal adjustment and coping difficulties. I think any chronic illness, the stress of that illness, the stress of the treatment, a natural end point to that is to have difficulty with coping and adjustment and kind of really often needing help just processing those changes and kind of how do they adapt. And sometimes that can become anxiety or depression, especially if not treated well, or some people just have a higher tendency for those, and making sure we're screening for that, assessing for that, and not only treating it with medications if necessary, but getting them plugged in with counseling and other resources to help learn how to deal with those feelings. Similarly, I mentioned that we're taking care of families as much as we're taking care of patients. And so sometimes it's having conversations and getting families resources to deal with different types of guilt or burden or kind of sadness that may be associated with seeing changes in their child. And so making sure that we're also taking care of our families at the same time. Similarly here, I think, as I mentioned before, kind of thinking through like the struggles with having less autonomy as you're needing more help with day-to-day tasks. And so this other quote that spoke to me was just this increasing level of assistance with daily activities can sometimes lead to a very well-intended overprotection from parents and or a learned passivity by the patient, that they just kind of defer to their parents who are their caretakers to make a lot of decisions moving forward. And so really our goal is to recognize that this can be a natural tendency, but really work to align our patients and our families, making sure we can talk truthfully about what do we expect in age appropriate ways and developmentally appropriate ways so that we can encourage kind of culturally sensitive conversations to get them on the same page to make sure we're all making decisions together. And I say culturally sensitive because each family unit is different in what makes sense for them and how they like to make decisions. And there are some patients who absolutely may not have the capacity to be involved in really complex decisions or may truly defer. And I want to make sure we've empowered them and we've given them the tools to want to engage, but it's okay if they defer that engagement, right? So navigating that and kind of making sure we're engaging the patient, the family, the healthcare team as much as possible to kind of make decisions together. So as we learn more from John, it's easy to see as you dig a little bit deeper that this is more just than kind of his physical body changing and physical diagnoses. When we think about his low back pain, of course, we want to rule out physical things. He's had spinal fusion. So is he having hardware malfunction? Does he have a pathologic fracture from osteoporosis? Are we maximizing treatment for contractures? Does he have the right equipment needed? A tilting chair, different padding and kind of equipment that can help make living life more comfortable. As I dig a little bit deeper, his low back pain actually wasn't related to his spine at all. It was probably more linked to some constipation and urinary retention that were kind of contributing to back pain. And while those are physical symptoms, the reason he was having those was coming from a more emotional place of coping and adjustment with more with requiring more help and needing more assistance with kind of his hygiene. And so he was withholding stool because he didn't want to go. He hated having to have help with toileting, with changing a diaper if they weren't able to get to a bathroom, those sorts of things. And so that stool retention was actually contributing to not only pain and discomfort, but was actually causing some urinary retention as well. He wasn't emptying his bladder well. And so that made him go much more frequently, which also put him out of sorts. It's that vicious cycle of he can't be in control of things when he doesn't know when he's going to have to urinate, or he's having to go so frequently he can't wait till he gets home and things like that. And so really it took kind of digging in a little bit more and exploring kind of the things he was worried about to help us know how do we actually better target our treatments for John. Similarly, we'd already mentioned he had swallowing difficulty. His friend that passed away had actually declined getting a feeding tube. That had been something really important to him and not something that he wanted. And kind of John saw this as a link to why maybe he didn't live as long. That's how he was interpreting it. And so he very quickly decided to get a feeding tube when he was having difficulty. And so he gets a good bit of his nutrition and of course all of his medications through his tube. He does still want to eat by mouth. He still can eat by mouth. He has a little bit of anxiety related to some choking spells on occasion. But we've started to see that he just has some chronic nausea, that he's not tolerating not only food by mouth, but even his tube feeds that he historically has tolerated well, even treating his constipation. Things just aren't setting as well. He's not as hungry. He's not able to keep as much down. And so that's been an issue for him as he's lost weight and contributing to some of that skin kind of breakdown or kind of thinning on his tailbone. Similarly, while he's used BiPAP at night for a long time, he's now having more shortness of breath during the day, and he's having to wear his BiPAP for naps during the day. He's sometimes putting it on while he's on his computer if he feels short of breath, kind of using that more and more. And so been partnering with our pulmonary doctor for a good long while, just talking about options for kind of more advanced breathing support, maybe even a tracheostomy or a long-term ventilator. And this is something where John has drawn the line in the sand, and he said, I just don't think that's for me. That feels like too much. And so kind of being able to navigate those decisions with John. One of the other things that I'll do as our patients are getting older is involve them in more advanced care planning. And so some of these natural conversations about feeding tubes or kind of respiratory support kind of lend to that very well, or kind of skew to that. But, now that he's an adult, he's 20, he's able to have an advanced directive. And so we've been able to walk through that with him and his family to make sure that he gets a say in the things that happen to him moving forward. And so, he's listed his mom as his power of attorney, his dad is secondary. He is full code, and he's kind of said, hey, if I get sick, I want you to give it a try. I want you to put me on the breathing machine and see if you can get me better. If I needed CPR, I'd be open to that until we could figure out more of what's going on. And so being able to kind of think through some of those very complex and kind of hard to discuss decisions. As I said, these discussions are dynamic. I've known John over 8 years. So, for a while, the hardest thing was to get him to talk about his bowel habits. So you can imagine it took time for him to talk about what was important to him in relation to feeding and breathing and things like that. And the decisions he made at the start were not necessarily the decisions that he kept with over time, and being open to new questions, new concerns, new curiosities as he's developing. And so as his breathing was worsening, as he was needing more support, and not able to do the things he wanted to do as much because he was so tied to that BiPAP, we actually discussed more with he and his family, our pulmonary doctor, and he changed his mind and ended up deciding to get a trach and a vent. And so this was a really big decision for him, and something that really was almost a 180 from where he had been earlier. And I can say I have guys that flip-flop and kind of have those, maybe want it and then decide not, and vice versa. And so being willing to kind of engage in those conversations and explore the things they're worried about and kind of hoping for is really important. His feeding intolerance, we actually figured out, was very closely linked to his breathing. He was having to work so hard to breathe that he was losing weight. He was burning calories. And so when we were able to help him breathe better with the assistance of a machine, he actually started gaining weight. He started tolerating his feeds better. And so skin started healing. His pain improved as he got a little more cushion, kind of in all those joints and along his sacrum. And then interestingly, kind of as he was using more technology, his goals actually changed. And he said, I'm already on a breathing machine. If my body were to get worse now, I don't think I would want you to put me through things like CPR. Or, certainly if you couldn't get me back to being able to breathe on a machine at home, I wouldn't want to stay on the machine forever in the hospital, and being able to navigate some of those complex conversations. He was still very clear that, hey, if I got a pneumonia, I want to go to the hospital. I want to treat that. I want to make sure I'm treating anything reversible, just up to a point of kind of recognizing what's worth it for him moving forward. And so I think he is a great example of that relationship over time, and different symptoms that we'd worked with over time, and different discussions that contributed to, that changed how we took care of him and made sure we were doing the right thing for him at the right time, and approaching kind of the concerns of his family at the same time. So all that said, I think, and as I alluded to earlier, I think the thing that I really love the most about engaging with this population is working to empower patients to be engaged in their care. And in order to do that, we have to make sure they know what to expect from their muscular dystrophy, whatever their diagnosis is, because that's different. Certainly different from muscular dystrophy, but even in the confines of Duchenne muscular dystrophy, we see lots of different trajectories, right? And so being open to them exploring that, and being willing to kind of sit in conversations about that. I think that can come with a level of concern, right? Kind of having these hard conversations with our children, as, no matter their age, but recognizing that so many of our kids are so smart, that they're online, that they have kids, friends from camp with muscular dystrophy, that they're learning from so many different avenues what muscular dystrophy can look like, what the complications could be, what life might look like, that being willing to kind of have those conversations with them is really important for them to understand. Secondarily, I think we have a lot of treatments that can help. And I've seen so many times that it's like, oh, because you have muscular dystrophy, you should take this medication and you should use this piece of technology. And we have lots of patients that historically have just said, nah, like, I don't like how that treatment makes me feel, or that mask isn't comfortable, or I don't know, that surgery sounds painful. I'm not sure I would want to do a spinal surgery, right? And so really wanting to explore what are the things they're worried about, but also making sure they know the why behind these treatments. It's not just we're doing this to do this, right? That there's, what is the doctor, what is the team kind of hoping for when we recommend BiPAP at night, or recommend that we find a steroid that does work for you, or take an ACE inhibitor that you can't tell a difference, in your day-to-day, kind of how it's helping. But helping them understand the why often helps them engage in those treatments and make decisions that make more sense. And then I think most importantly, making sure that we're not just thinking about the medicine piece, that we're really talking to them about what's important. Knowing you have muscular dystrophy, what's most important to you? What are you hoping for? What are you worried about? What are the things that you'd be willing to go through for the chance of more time? Asking some of those hard questions that really help us explore more of what our patients are hoping for and wanting, so that we can really encourage them to make decisions that make the most sense for them, that make the most sense for their family, based on what matters most to them. Because there's not a right or a wrong, right? Everything we're doing, we're always balancing the burdens and the benefits and the burdens of every treatment we offer, whether it's a pill, a machine, or a surgery, right? They all come with benefits, they all come with burdens and risks. And so helping them navigate that, I think, is really important when it comes to compliance and their willingness to take a medication, right? Or thinking about going through a tough surgery like a spinal fixation for scoliosis, whether or not it's worth it to find a mask that they can sleep in, and to be compliant with their BiPAP therapy, or even thinking about trach and ventilator down the road, whether or not they get a feeding tube, being able to engage them in some of these advanced care planning conversations so that they can always be engaged and kind of in charge of how we're taking care of their bodies and what we're doing to their bodies. And I had a great example of this just Monday in clinic. I got to see David, a patient that I've known for a while, and he was partnering with neurology. He is a patient that had historically not been able to tolerate steroids, had a lot of behavioral issues with steroids that really made life very difficult for him, for family, for teachers. So had tried prednisone and didn't tolerate it. It had tried Emflaza, didn't tolerate it. And so I was partnering with our neurologist to think about rotating him to the new Agamree, or the vamorolone, that has less side effects. And so she had done a beautiful job of talking about the importance of steroids, the why that we use steroids. And so he had engaged and said, it's worth a try, right? And so there are other things that he's done well. He's followed up with his cardiologist every year. He's on some great medications for that. Has never wanted, despite kind of recommendations from our pulmonary doctors, has never wanted to use BiPAP. And so does have significantly declining respiratory function. And so as I met with him after talking with neurology and the decision to kind of trial this new steroid, I was able to ask him, I said, David, what is Samantha hoping these steroids will do? Why do we want you on steroids? And he said, well, they're going to help me live longer. They help slow my muscle weakness so that I can live as long as I can. And I said, yeah, that's spot on. Absolutely. And that's why it's so important that we try to treat through these side effects and kind of see what we can do. I said, it sounds like, living as long as you can is really important. And he was like, well, absolutely. He's in college classes. He's studying to be a civil engineer. He wants to work on traffic, of all things. And he's like, I'm only a second year. I've got 2 more years of college, and then I want a job. And I want to be able to do those things and participate in class. And I said, I was so excited to kind of hear this and hear where he was in school. And I said, hearing that that's important to you, do you know that there's some other therapies that also help us with that? And he was like, well, what do you mean? And I said, well, taking your ACE inhibitor, for example, you've done that so well. I know you don't feel the difference, but that actually helps your heart stay stronger as well. And the one thing that I might recommend we think more about is if we actually re-talk about starting BiPAP at night. And he was like, why? Like, I feel fine, I sleep fine. But being able to connect the BiPAP with something that helps his lungs slow the progression of his lung disease, support his lungs longer, understanding that why and being able to link it to what was important to him actually made him go, okay, I'll talk to Dr. Truxler about that. I don't know, I might give it a try. So those are the things that when you can connect the dots, when you can really understand kind of their goals and then kind of the why of our therapies, when you can connect the therapy to their why, it really helps them engage and kind of make decisions that make sense for them and kind of being willing to try new things. So last but not least, and then we'll have some time for questions, when we think going back to our palliative care, what palliative care looks like for you and in your community is going to depend on the colors you're utilizing, right? To use our analogy. What specialists are in your community? Is there palliative care in your community? Do you have a specialist that partners with your MDA team? What symptoms is your child experiencing, and kind of what treatments are we trying or kind of looking at? I think local resources and culture, I know how palliative care works in Birmingham, Alabama, right? I know what my program looks like and how we engage with specialists. I can't say that it's exactly the same everywhere else. So knowing what the local resources are, some teams are inpatient, some have outpatient, some even do some home-based type care. It really depends on your community and kind of what resources are there. And then I think a lot of what I'm able to do depends on how you as patients and families are willing to engage. Are you open to exploring kind of these symptoms, these conversations with your child and with their providers? And the more open you can be to these conversations and having these complex discussions, the more helpful we tend to be able to be. So with that, I'll leave my contact information. I know Alexa's going to share these slides, but I want to open it up and answer some questions because I see a lot kind of coming through the chat.
Yes, we do have some really good questions. So thank you so much again for all of that information. I think, something I've been seeing in the chat is that this is something that is, has not been necessarily spoken about so much in the past. And I think, sometimes, at least, not recently, but it's all, there's been palliative care is hospice care, and that's just not true. So I think changing the narrative around it is really important. So thank you for that. So first question is, when you add palliative care to your multidisciplinary team, does that affect insurance reimbursement for needed equipment?
Absolutely not. So palliative care is an add-on. It's a specialty service, just like seeing your rehab physician or your neurology physician. It doesn't affect kind of what you qualify for from a medication standpoint, an equipment standpoint, a study or trial standpoint, anything like that. Now, if you think about hospice services, and I intentionally didn't speak a lot about hospice today because that's a very tail end thing that can change it. 21 and up, especially. So in our adult population, that can limit services. In our pediatric population, we have a lot more opportunities for kind of concurrent care, kind of with ongoing care, if and when hospice is appropriate. But for palliative care, it shouldn't change any opportunities for treatment, services, or equipment.
Awesome. Is palliative care appropriate for boys that are limited verbally and have significant developmental delays?
Absolutely. I think with anything, it kind of comes with more challenges, right? Especially being able to engage the patient and kind of really, I think I do my best to try to make sure I'm asking questions to patients in a way that they can understand or engage, even if it's a head nod, or maybe it's them looking at mom and saying like, I'll let mom answer. I would love to hear from you, but if you want mom to answer, I need you to nod yes or no, whether she's getting it right or wrong, right? So it makes it a little more challenging to get information directly from the patient sometimes. but our caregivers are very in tune, right? They're living with patients day in and day out. And so, you know, when they can fill us in on symptoms, and I think especially for a child that's nonverbal, they may not be as active in their decision making. And so then it's partnering with parents to be able to make those decisions and make sure we're thinking about what are the decisions in the best interest of my child, even when it may be something that's really hard for me to accept as a parent. And so making sure we're kind of thinking about decisions from the child's perspective or the patient's perspective if they're an adult patient at that time.
Yeah, awesome. And then when is the best time to start palliative care?
I think you can start it at any time. I can say, you know, we would love to say we see everybody from diagnosis on. You know, and we have 5 MDA clinics a month, and I'm in one of them, right? So some of it is access and what's available in your community. The earlier I get to meet folks, I feel like the more helpful I am, right? Because a lot of these conversations are more complicated, and getting a teenager or a young adult to open up and be willing to engage in these conversations takes relationship and rapport, and kind of building trust. And so I think being able to kind of just celebrate normal things, be able to engage and get to know you on normal clinic visits, even when you may not have a symptom at all for me to address, is super helpful. And knowing that over time, I may have a few more things to be thinking about, or, oh, this time we're talking about weight loss and feeding supplementation, and kind of let me navigate this kind of difficult conversation. And because we climbed this difficult hill, it's going to be easier for us to engage when we have a harder conversation down the line. So I don't think there's too soon. I think for some of my patients that don't have many issues at all, I may just see them once a year instead of twice a year. And others I'm seeing 2 to 3 times a year, right? Depending on what's going on, or I'm seeing them when they're in the hospital and in clinic. So I think you kind of ramp up what you're doing depending on what the patient's dealing with.
Absolutely. How long will palliative care stay involved? Is there a time limit or anything that would cause palliative to step away?
That's again going to depend on kind of your local resources, right? So I meet patients when they graduate to our adolescent young adult clinic, and I'm there for the long haul. I may not see them as frequently, right? But I'm there as long as they're in clinic. So I follow some of these kids for 10 years until they graduate to kind of the adult world. I think as I mentioned, there may be some that I see much less frequently and others that I see more frequently, depending on kind of what's going on and what symptoms need to be engaged. There may be other places, as I said, there's other kids in MDA clinics that I'm not able to see because I'm not in those clinics, right? So for those patients, our service is more limited. It's more limited to in the hospital. And then we see patients in clinic on an as needed basis. And so you can imagine those patients, sometimes we get to know patients and families kind of while they're in and out of the hospital over time, but it's less ideal, right? And so those tend to be kind of a come and go, more of a relationship, kind of to help for it to navigate an acute issue and acute decision, as opposed to kind of that more gradual approach and kind of navigating those ups and downs over time. So it just may look different. You may be involved more acutely and then kind of back off, and then kind of we're there in the background to kind of come back into play when you need us.
Absolutely. Do the care procedures differ between younger adults and those that are at the upper age ranges of Duchenne progression?
I'm not sure what we mean by care procedures.
I think probably does, I mean, you talked about in your presentation that it's obviously dependent per person. So if I were to answer this question based off of your presentation, I would say yes, only because the needs of the individual are different at the
right.
upper age as opposed to someone who's, 15, 16, 17.
Right.
So
And I have some 15-year-olds that present like somebody who's would be 22, right? And you're like, wow, how are we already here? And so
Right.
it really isn't an age thing. It's more of a what is their muscular dystrophy looking like? What are the issues that are associated that we're dealing with?
Absolutely. Let's see. What resources are available when they experience more of a sudden decline instead of a slower decline? I don't know if that's an easy answer.
I know that's tough. I think if you're already involved, right, then I know when patients have a quick change. Like our whole team gets notified if a patient gets admitted to the hospital in Birmingham or in Opelika, right? They're like, oh, so-and-so's in their community hospital. And so we're kind of talking with that hospital and figuring out when and if they need to come to Birmingham or if they can kind of get treated and stay home. So we may know if I'm already involved, I may know pretty quickly. Hopefully your muscular dystrophy team would know very quickly whether you got really sick at home or at a hospital. And so for a lot of palliative care teams, they're more involved inpatient. That tends to be where programs start. And so certainly if you're acutely sick and in the hospital, that may be the time that you meet palliative care for the first time. I have the luxury of getting to know a lot of these kids over time. And so I may see them, you know, if they're more acutely declining, they may follow up more often than our 6-month visits that we see in MDA, right? They may actually go to the pulmonary doctor for a quick check-in or the neurology doctor for a quick check-in. And so I may be able to pop down to their clinic as opposed to our regular clinic. So I think that depends. And it depends on what their goals are at the time, right? So if their goals are, I'm getting sick really quickly, I want to come to the hospital and figure that out, and kind of figure out how do we treat this, then we do that. If it's more of a, I'm getting sick really quickly and I don't want to go to the hospital anymore, that may be when we do some more telemedicine visits with clinic providers and figure out what are our goals. Do we need to be thinking about care at home as opposed to the hospital if that's what's important to this patient and this family? And that may be when we start to think about hospice. And kind of navigating that as an added resource. But that would really depend on what the goals were for the patient and the family more so than what was going on.
Perfect. Advanced planning discussion is tough to discuss with our dudes who are on the spectrum because we don't want them to focus on things that we don't know if and when will happen. I've had to ask questions and plant seeds without too much focus. Any experience or suggestions for those that are dealing with that situation?
That is, I think, one of the more challenging pieces of the care we provide. And knowing that these complications and decisions are probably coming at some point, but not knowing the when, right? So for some of our patients, it's a very slow, like predictable, and sometimes we have those acute changes. And so sometimes the earlier we can be planting those seeds and having pieces of that conversation, kind of the better. I think what's been most helpful for me is normalizing the conversation. So just like we talk to every kid about breathing and eating and weight, we're talking about decisions. And especially once they're like in that 18, 19 range, I talk with all my patients as they reach adult age, especially before we transition to the adult world, about making more decisions and taking ownership of the decisions and how we take care of you. And so being able to normalize that to say, I have this conversation with everybody. And this is an important conversation for you because you have muscular dystrophy, but honestly, it's an important conversation for your mom to have and your dad to have, and for me to have with my family. And so trying to normalize that as much as possible is helpful. And then really approaching it from a, thinking through more of a, what are you hoping for? What are you worried about? I think those questions are actually more helpful than writing an advance directive. Having the people that know them know, like, what am I hoping for? What am I willing to go through if I have more time? Even if I'm living in a more dependent state or I need more technology, like, what am I willing to go through? And being open to some of those conversations at least give us ideas of what's important when and if we have to make those decisions down the road. And then last but not least, I think, especially as we're getting to know kids and as families are helping me get to know their children, like if being in control and making decisions is important, setting up advanced care planning as this is the way that you stay in charge. This is the way that you get to make your decisions and you get to make sure your parents are making your decisions, even if you get sick really quick and can't talk with us for a while. Right? We're hoping that we can get you better and that you can talk to us again. But in the event that you have a breathing tube down your mouth for a while and can't communicate as effectively because you can't use your, you can't write like you do at home or use your computer, if we can have some of these conversations earlier on and kind of so your mom knows what you want to do or your dad knows, that helps us get back to what do we do right now until hopefully we can get you to a place where you can tell us more. So there's lots of different techniques, I think, depending on that relationship and kind of that particular patient and kind of how they experience those conversations.
Perfect. So we have two questions. One is, does supplements help with muscle pain? And I think that would probably be dependent on, the person and what that looks like. And then we have another question about research on steroids that extend the lifespan. So I will connect with you offline and share that information with that individual. And then Alicia, I just saw your question. We will have this is recorded, so we will send this after the fact. So if you missed any of the answers from the questions, you are absolutely welcome to go back and listen to that. It will be available for you in the next few days. So I want to thank you all again for being here today, listening to our webinar. Thank you, Dr. Nichols. Again, this was absolutely amazing and something that I think we need to talk more about in the future. Thank you, and we will see you all again soon. Bye, guys.